Hello everyone. So today we are going to discuss case number 284 of medicine. A 59-year-old hypertensive patient is brought to the emergency room with excruciating chest pain not relieved by pethidine. His BP is 200 over 115 in the right arm. All the peripheral pulses are palpable except the left leg. What is the appropriate investigation? So first of all, you have to make the diagnosis in your mind, and then you have to tell what will be the investigation of choice for this disease. Alpha echocardiography, beta ECG, Charlie chest x-ray, and delta CT angiography. I am going to give you 5 seconds so that you can answer this question by yourself. Yes, you got it right. The answer is D, CT angiography. Let's discuss why this is the answer. Our answer is D, CT angiography. Why this is the answer? Because the presentation of this patient suggests that the patient has aortic dissection. The patient has hypertension, patient has severe chest pain, and patient has pulse deficit that are classical for aortic dissection. What is aortic dissection? It is a tear in the inner layer of aorta that lead to the progressively growing hematoma in the intima. Got it? No? So I am going to share with you an image. This is our healthy vessel. We have three layers of the vessels. In between, the deepest one is the intima. That is what is facing the blood, and then we have media, and then outermost is adventitia. So I am saying that the aortic dissection is a tear in the inner layer called as intima that lead to the progression to the hematoma. I mean the blood is going to move between these layers. Look at this image. This is the dissecting aneurysm. Look, the blood is going inside the intima and between media, and these layers have a collection of blood inside them. So this is the aortic dissection. So what is the most confirmatory test about that? This is the CT angiography. Okay, let's discuss why not the other options are correct. We have echocardiography that is useful if the patient is unstable, but our patient is not unstable. And uh, which are better? MRI and CT, especially CT angiography is best one. Which is our question. ECG may show ischemic changes if there are, but cannot diagnose aortic dissection. And what about chest X-ray? Chest X-ray will show you widened mediastinum, so you have to rule out why this is widened mediastinum. Maybe it is aortic dissection, maybe some other condition. So chest X-ray will just show you widened mediastinum. We have to rule it out by doing CT angiography. Let's discuss some other important point that will help you in future. If they ask what is the gold standard test for aortic dissection, the answer is CT angiography. This is our today's question. If they ask what is the most common risk factor for aortic dissection, the answer is hypertension. Our patient is hypertensive actually. If they ask what is the initial treatment for aortic dissection, so the answer is IV beta blocker. For example, labetalol we can give initially and with not very complicated patient. Okay, so we go with IV beta blocker labetalol. If they ask what is the treatment for aortic dissection, so it depends upon the classification of aortic dissection, what class of aortic dissection this patient is suffering from. Yes, there are classes like I will tell you in a second, but bear with me. If the patient is having aortic dissection type A, we can do emergency surgery because it's a very critical situation. If we other on the other hand, if we have type B, which is complicated, then we do urgent TVAR. What is TVAR? TVAR is also called as, it is the acronym for thoracic endovascular aortic repair. In this process, we do a minimally invasive process where we place the stent via femoral artery to the aorta. We go from the femoral artery to the aorta where the dissection is. We place the stent for preventing this artery from further damage for further complication. And if the situation is very bad, then we can do open surgery like type A. Okay, if uncomplicated B, then we can go with labetalol IV blocker. Conservative management should be done, especially we have to lower down the hypertension. If they ask what are the classification system of aortic dissection, there are two. One is called as Stanford. It has two types, type A and type B, and other system called as DBA. This is a different classification. There is a slight difference I am going to tell you in a second. And what is the most common cause of death in aortic dissection? This is the aortic rupture. So basically, stunting that we were doing in TIVAR was also for preventing the aortic rupture, because when these patients go into the aortic rupture, they are very prone to aortic rupture, and whenever the patient go into aortic rupture, this condition is very, very critical for the patient for his survival. Okay. Now coming to the classifications, there are two type of classifications, Stanford and DBA, and Stanford has further types and DBA also have further types. Let's go to the image. So in this image, I am going to show you two classification system. One is Stanford upper side. So what Stanford say, then we will come to the DBA. You know, the aorta is divided. Aorta has different names like ascending aorta, and then we have descending aorta, okay, and aortic arch. Here we have aortic arch. This is ascending aorta. Then we have this portion. This is called descending aorta, okay. So basically, if the ascending aorta is involved, I'm repeating my statement. If ascending aorta, this portion, ascending aorta, is involved, has aortic dissection, we will mark it as Stanford type A. If ascending aorta is suffered, we call it Stanford type A. If descending aorta is involved, then we call it Stanford type B. And sometime also descending and ascending aorta both are suffered, then what will be the answer? Stanford A or Stanford B? The answer will be Stanford A still. So you have to just memorize that whenever the ascending aorta is involved, we call it Stanford A. Regardless of that, uh, if the patient is having the involvement of descending aorta or not. So Stanford is basically on the involvement of ascending aorta. So there is a problem. You see that Stanford classification has a problem because it is placing both in one place. Like a patient is, first of all, let me simplify with it. If the patient having ascending aorta, this is Stanford A. If the patient has descending aorta involvement, this is Stanford B. But when two of them combinedly present, we also called it as Stanford type A. So the scientists come with a new idea, with a new classification that is called as DBA. So DBA has three types: type A, type 2, type 3. What they say? They say if both ascending and descending aorta are involved, we call it type 1. Okay, DBA type 1. If only ascending aorta is involved, this is called as type 2, and if descending aorta is only involved, this is called as DBA type 3. Okay, so you see that the Stanford type A is more critical because it is involving ascending aorta, and also if Stanford, this type of Stanford is present, this is very, very dangerous. And if the aorta, only the ascending aorta involved, this is also very dangerous because all the vessels will come out from after that, especially the brain arteries are coming out. So we have to treat it like emergency surgery, I already told you. And if we have Stanford type 2, so it depend upon the patient condition. We can place patient on TIVAR, or we can also use IV labetalol, beta blockers for prevention of further complications. So this is all about aortic dissection. Thank you for your attention.